We're introducing Dr. Bhalla, who's the Chief Quality Officer at Montefiore Medical Center, Assistant Professor of Medicine at the Albert Einstein College of Medicine. Dr. Bhalla oversees the performance and quality improvement activities for the Montefiore Medical Center. And having once had that role myself, I can vouch that it is a considerable portfolio. It goes across the integrated delivery system, and he has led organizational initiatives to improve performance in a number of areas, including patient and provider medication safety, disease and care management protocols, preventative care, patient and provider satisfaction, and healthcare disparities. He also has a somewhat unique background in that he is a hospital administrator who has in fact been grant funded 3 times to do research. He's had a Robert Wood Johnson grant to remove disparities in cardiac care. He has a New York State Department of Health grant for over $2 million to measure the impact of pay for performance on healthcare quality in our system. And just 2 days ago, I believe, got his second Robert Wood Johnson grant to look at the impact of pay for performance on healthcare disparities, plus or minus what the impact is. There's a big focus on that. He's a graduate of the 6-year BA/MD program at the Boston University School of Medicine. He's board certified in internal medicine and public health general preventative medicine, which he completed at the New York City Department of Health, and he has an M.P.H. from Columbia. Without further ado, let's welcome Dr. Bhalla. I have one observation here. This is like a personal introduction. I had the opportunity to recruit Dr. Bhalla to Monty, and I had sat him down for an interview, and when I finished, I hired him without an approved salary line. So I think that says it all.
Thank you, Brian, for that generous introduction. I actually want to double check if that salary line is still there. You know, we have 2 very rambunctious kids at home, and I would love to get a transcript of that introduction to read to them tonight. I might actually get some respect. My talk is entitled T3 Translational Research in a Complex Healthcare Organization, and I'm going to talk about that. I first want to just to say thank you to Brian and to Harry Shamoun and to Paul Morantz for the opportunity to speak here. There have been many translational models probably put forth today, and I would be worried I might collapse the podium if I put forth another one. So what I'll do instead really is just to utilize this as kind of a conceptual placeholder to put my talk in context. And this is a translational model from a paper that was in JAMA earlier this year from Doherty and Conway. And they talk about the continuum of translational research. And my purpose really is just to acknowledge that there is a continuum. There are different types of translational research. And I will be talking a little more about T3, and rather than to go into any depth about a model, I'll just simply quote what they said, which is that T3 activities encompass the essential 3rd step along the 3 T's roadmap. T3 activities address the how of healthcare delivery so that evidence-based treatment, prevention, and other interventions are delivered reliably to all patients in all settings of care and improve the health of individuals and populations. So what I'd actually like to do for the next 20 minutes or so is to talk about that how, but a little bit more at a ground level in the context of a project we did, because I think that's perhaps most illustrative of at least the challenges and opportunities that we have in terms of conducting these types of initiatives. So this subsection is entitled Research in Patients, Practices, and Communities. The subheading for this presentation is for this symposium is bridging the translational divide. And what I want to talk about is that dichotomy between service, delivery, and evaluation, and think out loud with you in terms of the degree to which these activities can enrich each other and complement each other. So the questions I hope to answer for you by the end of this 20 minutes or so is this line permeable Should these efforts be conducted in parallel or series? Should we deliver operations and then evaluate them and wait for those studies to come out, then change operations? And then correspondingly, a somewhat rhetorical question, is the relationship synergistic? So I'm going to start with my operational hat on in the sphere of healthcare service delivery, and what I hope to do actually is to walk from the left to the right, stop on the right, to actually ask what did we accomplish with respect to, with respect to this project, and then to go back to see how that project may help enrich healthcare delivery. So I'm going to start with this case study, which is the Robert Johnson Foundation program. It was known as the Expecting Success program. It just finished. I was a principal investigator, Brian, project director. We got a lot of help. Steve Safier was our executive sponsor. Hal Strelnick was instrumental in helping us think about this program. This was a program, in a nutshell, that effectively started to challenge organizations to start to take some baby steps in terms of thinking about what they would do to their own systems to start to address the issue of disparities in healthcare, which is no news to this group. But the national program objectives are there, and it was to improve cardiovascular care, heart attack and heart failure care for African Americans and Latinos, of course, which are the populations in which disparities have been described, and for those same conditions. Develop improvement strategies and share lessons with healthcare providers and policymakers. But if you look at this map, the interesting thing is that if you look at the communities that are represented there, these are not typically the communities you would think of as kind of the grant-getting communities. One of the criteria, even though this was a competitive process, was that the community itself was what you might call a minority-majority or majority-minority community, where over 50% of the population was African American, Black race, or Hispanic Latino ethnicity. And in fact, one or two of these institutions not even have an institutional review board. So just a little bit of context in terms of talking about this project, because I'm going to talk about it from the perspective of operations and intervention first, and then with you think about what did we actually accomplish doing this. And so, of course, this is also, I imagine, no news to this group. The Institute of Medicine articulated aims for the 21st century healthcare system, talking about improving not just simply effectiveness, but safety, timeliness, efficiency, patient-centeredness, and equity. And so I think that was really the question, is that if you ask organizations what are they doing about the equity issue, invariably you would probably not get a lot of very focused answers, but there would be a lot of citing of descriptions of disparities. And so complemented with that is the work on equal treatment, which again, no news to this group, is that racial and ethnic minorities are less likely to receive even routine medical procedures and experience a lower quality of health services. And so that really was the backdrop of this initiative, was to try to now start, and I don't want to speak and wouldn't speak, of course, for the foundation, but to try to move from a culture of description, if you will, in this arena to a culture of action. What are we actually doing about this? So here was our project. We effectively sought to do what was a major intervention was to really standardize the collection of demographic information at Montefiore. And that involved looking at collection of race, ethnicity, and preferred language information in a systematic way, training registration staff, modifying our information systems. I'll talk a little bit about that. And then accordingly, in these minority-majority communities, to improve heart attack and heart failure care, having developed the capability to take a look at standardized demographic information, to then look internally ourselves at how are we doing at delivering this care to different groups of persons that we treat. And then accordingly, a element that looked at improving communication with post-discharge providers. And rather than go through the measures, I will share some of the data with you to try to illustrate how we did on that. So here are some interventions, and these were superimposed on a number of improvement interventions that we put in place around heart failure and heart attack care during the life cycle of the project. But these are things that you might think that we would do in an improvement effort. We created guidelines that were more simple, colorful for physicians. We created patient education materials that were a little bit more easy to comprehend. We sought feedback from members of the community in terms of how to think about that, created some dietary guidance that resonated with ethnic cuisines. And we also worked with a number of different constituencies at the medical center to create some changes, one of whom was the registration community, who I think I mentioned, because you would not think of that community typically as a go-to community in terms of doing translational research, but in fact this community was instrumental in helping us make some of the changes that we made. And this was some of the material we developed just to broach the discussion and to talk about the importance of collecting this information in a systematic way. So now I've talked a little bit about the interventions, and what I want to do now is stop on the right side and talk about the evaluation piece. What did we actually accomplish by doing this? Because I think that beyond even the discussion about what we accomplished by doing this, I think some of the issues that arise out of looking at that data are very important in terms of thinking about how to conduct translational efforts within the T3 sphere and some of the challenges that arise. So here is the effect of the registration system changes. What we effectively did, believe it or not, the registration community at Montefiore is over 600 people in and of itself. It's at over 80 sites. It was not a benign thing to try to standardize this process. There were a lot of meetings and auditoriums that happened and so forth. But we collaborated with a number of different entities, including our registration community, information technology, customer services, and so forth, to make these changes. And here is, just in terms of the effectiveness, the proportion of discharges at Montefiore that had unknown demographics before and after the intervention. This is for race, ethnicity, and preferred language, which were the three demographics we were most focused on. You can see that there were reductions in the proportion of discharges. Montefiore discharged something like 65,000 people in 2005. In 2007, it was about 71,000. And you can see the reduction there from 47 to 29%. Unknown demographics and race, 62% to 9%, and 97 to 3% preferred language. So this was not simply a matter of making changes to the IT system. It was also working with the registration community, getting their feedback on their reservations about this process, as well as then making the change and kind of course correcting based upon their feedback. So that's one of the key interventions, but then the question becomes, what do you do with that? And so here is just some standardized quality measures that have been developed by, promulgated by various professional societies, endorsed by the National Quality Forum, National Committee for Quality Assurance. This is what we actually looked at during the life cycle of the project. And what's noteworthy for these measures, of course, is these are process measures, univariate things to look at, but nonetheless variables that we know impact outcomes. And so that's what we looked at during the life cycle of the project. And they encompass things like giving an aspirin at arrival for heart attack, if you're a candidate for balloon angioplasty, getting that procedure within 90 minutes and so forth, comprehensive education for heart failure patients and so forth. So here's what happened over the life cycle of the project. It was a project that was effectively operational from Q106 to Q108, a 2-year period. And what's depicted here is what's called by some policymakers as ideal care or perfect care. You could call it all recommended care for heart attack and heart failure patients that we saw. And essentially what that is that basically takes each individual heart attack and heart failure patient and asks the question, what interventions are you eligible for? So if you're a heart attack patient who was a smoker, you're eligible for smoking cessation counseling. If you were a candidate for angioplasty, it would then ask the question, did you get that procedure within 90 minutes? It's not actually a composite measure. It's more of a dichotomous look at whether a patient, yes or no, got all of the things that they were supposed to get. So if you get 4 out of 5, you're not a success. If you get 5 out of 5 or 3 out of 3, 2 out of 2, you are a success in this measure. So you can see that over time we improved recommended care from 68% to 85% for heart attack patients, from 47 to 78% from heart failure patients. So here is the other capability that was generated in terms of thinking about now how the organization can change its systems. Is we effectively then took a look at our information by those demographic groups. So on the left is effectively, in calendar 07, the proportion of patients at Montefiore who received quote-unquote perfect heart attack care, at least in the inpatient setting. And you can see that that was 80%. But then you see that red dotted line, which is the same line I showed in the beginning, which is kind of the capability we created as part of this project. And there you see that we then took a look at Montefiore, how are we doing with respect to the delivery of cardiovascular processes of care with respect to subgroups. And So you can see there that we looked at black versus white race, Hispanic versus non-Hispanic ethnicity, and English versus Spanish preferred language. We did not find actually any significant differences. Of course, this is only inpatient processes of cardiovascular care that we were looking at. But I think the key thing from the point of view of that initial concept that I tried to introduce in terms of service delivery versus evaluation is that before this project, we would have been on the left side of that red line looking at 80%. And so the operations people will tell me that that's great. You improved recommended care from 60 to 80%. That needs to be at 100%. The research community will tell me that that's great. You're looking at Hispanic versus non-Hispanic and so forth, but identity and notions of race and ethnicity are much more complicated than that, and that's a very crude descriptor. And both of those are, of course, valid concerns, but prior to this effort, we certainly would not have been able to do either of those things. What I think this brings up for me is in terms of thinking about research versus this project, this subset of talks is entitled Research in Patients, Practices, and Communities. What does that actually mean in terms of doing projects like this? Well, I think in contrast to what you might call traditional research, and I don't hold this out necessarily as a very rigid line here, but more I think conceptually as an area of demarcation. That of course research is investigator initiated. This project required a great deal of leadership, stewardship, because if you're going to tap into the organization's IT systems, a community of 600 people who are employees of the medical center, you have to have executive support for the project. The grantee, of course, in research efforts is an experienced investigator. Here, who the community was and its demographics also entered into the award process. Project personnel dedicated, of course, in research activity, and this project we relied heavily on several organizational personnel. In research, we protect results obviously until they're published. However, in this project, it was somewhat of the reverse. Information sharing was paramount. There were 7 national meetings that I dragged Brian to across the United States, much to his chagrin. And we met with other grantees, and one of the major purposes of those meetings was to share what was working, but even more importantly, what really was not working in terms of what we were doing at the various sites and trying to improve care. And then, of course, coincident with that is the notion of IRB, of course, approval being a prereq in research. Here, one might say optional, in quotes, because this was an improvement initiative. The publication imperative is, of course, primary in research, perhaps secondary here, although we have convened a publications committee and are actively working on getting the findings out from this initiative. And I know many of the researchers here will stare aghast at my term there, large, for awards under research, but my only point in putting that there is just to make the point that in terms of the notion of the award size and overhead, very much on the low side for a project like this, because the foundation was really looking to create some kind of systems change at the organizations they work with that would live beyond the life of the project. So methodologic limitations, and with my operational and research hat on, I worry a lot about these things. The intervention components in research are discrete. We take great care in atomizing the various interventions so we can measure those different interventions. Here it was consolidated. I talked about educational materials, provider materials, and so forth, some of the improvement work we did, but a very kind of amorphous intervention, if you will, although time demarcated. Comparison group, of course, present in research often, in this project absent, which is a huge issue. Measurement issues, of course, you have dedicated databases and focus on outcomes in research. Here, we utilize organizational database, which poses its own challenges for doing these types of initiatives because your data collection can sometimes tick on an organizational clock, which can sometimes tick very slowly. And of course, look at univariate processes. So one of the things I worry about most from an analytic perspective is the fact that we don't do a good job of accounting for secular trend bias, which is a huge issue. And so we do have some compensatory mechanisms, though. And so operationally, what we rely on a lot is effect size. So I've talked at a very high level about this project and ideal heart attack and heart failure care. Time doesn't permit talking about any of the individual measures in great detail, but just by way of illustration, in terms of one of the activities we were working on as a sub-heading, we looked at door-to-balloon time improvement. So getting people who need an angioplasty to have that procedure within 90 minutes. And you can see we went from 10 to 100%. So large effect size, no comparison group, but still allows us to feel reassured that we accomplished these things. We're able to actually pull some comparison data for this for the U.S. as a whole for this particular measure. So, so just having stopped there to kind of critically thought about what we actually accomplished during this project, the question then becomes, now that you've actually created those capabilities, what can you do in terms of enriching healthcare service delivery? And so here is, we looked at some univariate processes. Here is some same-cause readmission data on cardiovascular disease. What you might typically see is on the left. This is same-cause 30-day readmission rates for different cardiovascular diseases. And what I think would pop up to anybody who's interested in improvement or policy is that heart failure is sticking out there at 13.4%, obviously where we should put our efforts. But now, given the fact that we have some of these capabilities, we can start to think about this a little bit differently. We can think about perhaps demographic-specific utilization rates. Are not the issues related to management of care common for certain groups? Medication compliance, adherence, keeping follow-up appointments, those are common dilemmas for chronic disease in general, and it makes us start to think about whether we can conceptualize disease management programs a bit differently. And then here, if you take a look at our ability to somehow deliver healthcare services in a more patient-centered way, on the left are depicted core operational functions that we think about every day: health information management, patient education, nutrition, and so forth. But now, with a little bit of this capability ingrained, we can now think about enhancing those services, language-specific forms, patient-centered materials, specific dietary advice. Those now become possibilities to enhance and enrich our operational endeavors and to better serve, of course, the community. So I'm going to close in a few minutes, and I wanted to actually close because I talked about the fact that what we improved recommended care for heart failure, heart attack, and so forth. Didn't spend a lot of time talking about any specific efforts. And I thought it would be instructive to just take 1 or 2 minutes to talk about this because we always talk about the term translating evidence from bench to bedside, applying what the literature says to our practice. And the one point I wanted to make, which I don't think I may have made effectively in talking about this from an overview perspective, is that it becomes very important to do translation in the reverse direction. So here's a paper from the New England Journal that was published by Bradley and colleagues in 2006. It was a multivariate analysis that looked at the independent effect of various process interventions, what characteristics and what implementations did organizations put in place to actually improve door-to-balloon times. And you can see here that if you take a look at the notion of the EMTs actually transmitting electrocardiographic results prior to arrival in the hospital, that organizations that did that, adjusting, holding other factors constant, on average had about a 9 or 15-minute reduction in their door-to-balloon time. So that's the literature. Translating from the literature to the practice, one would think that, of course, what you need to do is to then do that at your own institution. But what I wanted to just mention briefly is that equally important is taking that literature and translating your local environment back to the evidence. And so the question becomes, how do patients in the Bronx who are candidates for PCI present? And so here you see the mode of presentation for 100 primary PCI patients at Montefiore. You can see that about 40% walk in. They don't come in via ambulance. 60% come in via ambulance. This is an urban environment. There are well over 5 ambulance carriers in the Bronx who are bringing these patients in. So what that means is that simply translating the literature to our local environment would have resulted us in probably doing a very good job with this one carrier and having pre-hospital ECG, but probably not improving services for the community. And so it was this data, I can assure you, will not make it to the New England Journal of Medicine, but nonetheless becomes extremely important and integral in terms of designing kind of community-centered and tailored approaches, if you will. So I'll close here just by saying that I think what I hope I've tried to convey, again, from the construct of a case study as opposed to a conceptual model, is that I do think this line is permeable. I think very much that these efforts need to be conducted in parallel. I don't think we have the time to wait for these things to be done in series. And I, of course, think that this relationship is synergistic, as I think we were able to leverage in this particular program. Thank you for your time.